Welcome to the IRF and LTAC Virtual Training Program, Part 1. My name is Charlotte Stineger, and I am presenting Section C, Cognitive Patterns. I'm a registered nurse with experience in acute and post-acute direct care, nursing education, and quality management, specifically in the home health setting. Currently, I'm a senior staff associate at Econometrica in Bethesda, Maryland. At the conclusion of this training, you should be able to demonstrate an understanding of the standardized patient assessment data elements identified in Section C, Cognitive Patterns. Describe the intent, coding instructions, and definitions for the Section C items. Note that both Section C items are new for LCDS, and though we will touch on the changes to both manuals, it is highly recommended that you review the entire content contained within the guidance to ensure your complete and full understanding of this section. So we'll start with an overview of the items in Section C for both IRF-PAI and the LCDS. Now for IRF, there are some general revisions to Section C and a new item, and these include that a new discharge item for C0100 shared a brief interview for mental status C0200 to C0500 be conducted. This was created specifically as a new discharge item for the IRF. We clarified guidance for C0100 should brief interview for mental status C0200 to C0500 be conducted. We clarified guidance for C0200 to C0500, the brief interview for mental status, we know as the BIMS. C0600 should the staff assessment for mental status C0900 be conducted, and C0900 memory recallability are both clarified in the guidance. And then, as I mentioned before, we have a new item, C1310, signs and symptoms of delirium from the CAM. As mentioned before, the items in Section C are all new for the LTAC care setting. And they include C0100 should a brief interview for mental status C0200 to C0500 be conducted, C0200 to C0500 a brief interview for mental status known as the BIMS, and C1610 has been replaced with C1310, signs and symptoms of delirium taken from the confusion assessment method known as the CAM. The intent of Section C is to determine the patient's attention, orientation, and ability to register and recall new information, and if the patient has signs and symptoms of delirium. So let's see how we exactly do that. We start by discussing C0100. Should the brief interview for mental status C0200 to C0500 be conducted? Now, this is a new item for LTAC, and it's been slightly revised for IRF. It's collected upon admission and discharge. Now, the intent for C0100 is to identify if the brief interview for mental status, known as the BIMS, will be attempted. And there are a number of things to consider when you approach this interview. This is a structured cognitive interview, which means that everyone should conduct the interview the same way, but more on this point later. Most patients should be able to attempt the BIMS. Structured cognitive tests are more accurate and reliable than observation alone, and this can prevent mislabeling a patient based on appearance. And finally, conducting structured cognitive tests can provide insight into a patient's condition and therefore enhance the care provided. So let's review the steps for assessment for this item. Note the text in blue font identifies a change to the IRF-PAI guidance. Now, for my LTAC friends, this is all new. So number one, we're going to interact with the patient using their preferred language. And be sure the patient can hear you. Provide access to their preferred method of communication. If the patient is unable to communicate, offer alternatives, writing, pointing, sign language, cue cards. And determine if the patient is rarely or never understood verbally in writing or using another method. If rarely, never understood, you're going to skip items C0200 to C0500, the brief interview for mental status. Moving on to coding instructions for C0100. For IRF and LTAC, you're going to complete the assessment as close to the time of admission or discharge as possible and record whether the cognitive interview should be attempted with the patient. Now for LTAC, you're going to complete only if A0250 is 01 admission or 10 planned discharge. And for the actual response codes, you're going to code 0 no if the interview should not be attempted because the patient is rarely, never understood, The patient cannot respond verbally, in writing, or using another method, or an interpreter is needed but not available. Then you'll skip C0200 to C0500 brief interview for mental status. Code 1, yes, if the interview should be conducted because the patient can sometimes be understood verbally, in writing, or using another method, and an interpreter is available if needed. Proceed to C0200, repetition of 3 words. And remember, we are going to try to conduct this interview on all patients. So let's look at the general guidance for conducting the BIMS. Now, these are, again, new items for LTAC, and though IRFs have been collecting this for a while, there are some changes to the guidance that we will be reviewing. So the BIMS is comprised of 4 sections: C0200, repetition of 3 words; C0300, temporal orientation; C0400, recall; and C0500, the BIMS summary score. Now, later we will take a closer look at each of these items, steps for assessment, coding instructions, and tips as they apply. So why are we doing the BIMS interview? So it's been found that direct or performance-based testing of cognitive function decreases the chance of incorrect labeling of cognitive ability and improves the detection of delirium. Cognitively intact patients may appear to be cognitively impaired because of language barriers, hearing impairments, or a lack of social interaction. In addition, some patients may appear to be more cognitively intact than they actually are. If cognitive impairment is incorrectly diagnosed or missed, appropriate communication, worthwhile activities, and therapies may not be offered. And note for IRFs, when you review the guidance, you'll see that the item rationale for these items was refined to enhance some clarity. Now, let's take a look at the steps for assessment. And again, for IRF, these will look similar to what you already know, with a few refinements. So we'll start by reviewing the basic interview instructions for the BIMS, C0200 to C0500. We are going to start by informing you that there's this supplement B that actually reviews the basic approaches for effective interviewing techniques. Really important document to take a look at. Number 2, we're going to interview any patient not screened out by item C0100, should the brief interview for mental status be conducted. We're going to conduct the interview in a private setting, if possible, and be sure the patient can hear you. Patients with hearing impairment should be tested using their usual communication devices techniques as applicable. Try an external assistive device, headphones or a hearing amplifier, if you have any doubt about a patient's hearing ability, and we'll always try to minimize background noise. To continue, we're going to sit so that the patient can see your face, and minimize glare by directing light sources away from the patient's face, and provide an introduction before starting the interview. So some suggested language is the following. We would like to ask you some questions. We ask everyone these same questions. This will help us provide you with better care. Some of the questions may seem very easy, while others may be more difficult. And finally, if the patient expresses concern that you are testing their memory, reply, we ask these questions of everyone so we can make sure that our care will meet your needs. Directly ask the patient each item in C0200 through C0400 in one sitting and in the order provided. So if the patient chooses not to answer an item, accept their refusal and move on to the next question. We will handle how to address nonsensical responses later in the presentation. So for C0200 to C0400, code refusals as incorrect, no answer, or could not recall. Okay, for the coding instructions. In general, for IRF and LTAC, you're going to complete the assessment as close to the time of admission or discharge as possible. For LTAC specifically, you're going to complete only if A0250 is 01 admission or 10 planned discharge, preferably during the first 3 days for admission. And we'll cover more specific coding instructions for each of the items contained within the BIMS a little later in the presentation. So here are some coding tips to consider. If a staff member is unable to articulate or pronounce any of the cognitive interview items clearly for any reason, an accent or speech impairment, have a different staff member conduct the BIMS. Nonsensical responses, incorrect answers, and questions the patient chooses not to answer should be coded as 0. The interviewer should track the reason for coding the answers as 0, as this information will be used later for coding the summary score in C0500 BIMS summary score. So when you're ready to conduct the BIMS interview, be sure to have a place to capture notes like this, a pen, a notepad. These notes will be important later. In the next few slides, we'll cover important guidance regarding stopping the interview and what to do with an incomplete interview. The terms on this slide will help provide some context. So a nonsensical response is considered any response that's unrelated, incomprehensible, incoherent, and not informative with respect to the item being rated. So a complete interview is also an important concept here. The BIMS interview is considered complete if the patient attempted and provided relevant answers to at least 4 of the questions included in C0200 to C0400C. Now, the relevant answers do not have to be correct, but they do need to be related to the question. So let's talk about stopping the interview. You'll stop the interview after completing C0300C, day of the week, if responses to all items have been nonsensical, meaning that any of the responses are unrelated, incomprehensible, incoherent, not enough information with respect to the item being rated, or there's been no verbal or written responses to any questions up to this point, or there's been no verbal or written responses to some questions up to this point, and for all others, the patient has given a nonsensical response. Okay, so now that you've stopped the interview, what do we do? So we'll start by coding a dash in C0400A, B, and C, and code 99 in the summary score in C0500 BIMS summary score. And for IRFs, now this is new guidance. If the interview is stopped, code 1, yes, the patient was unable to complete the brief interview for mental status for the item C0600, should the staff assessment for mental status C0900 be conducted, and then complete the staff assessment for mental status. Here are a few more coding tips for your consideration. When staff identify that the patient's primary method of communication is in written format, the BIMS can be administered in writing. We invite you to consult Supplement A in your setting-specific guidance manual for details on how to administer the BIMS in writing. If all responses to C0200, C0300A, B, and C are 0 because answers are incorrect, continue the interview. So let's stop for a second here and think about this. You can use code 0 for a number of reasons. An incorrect answer, if the patient chooses not to respond, or if the answer is nonsensical. But whether you continue the interview past C0300C depends on the reason why you coded those items as 0. See how that pen and notepad would come in handy? Let's delve into this a little bit more, shall we? Here we go. Code 0 is used to represent 3 types of responses. Incorrect, unless the item itself provides an alternative response code. Nonsensical responses, questions the patient chooses not to answer, or refusals. So zeros resulting from these 3 situations are treated differently when coding the summary score in C0500. The interviewer might find it valuable to track the reasons for the 0 responses to assist in accurately calculating the summary score in C0500. So let's review some examples. So an incorrect answer. The interviewer asks the patient to state the year. The patient responds, "It's 1935. This answer is incorrect, but related to the question. So we are going to code this as 0 incorrect, but would not be considered a nonsensical response. The answer is wrong, but it is logical and relates to the question. So let's look at a refusal. The interviewer asks the patient to state the year. The patient responds, "What difference does the year make when you're as old as I am?" The interviewer repeats the question and the patient shrugs. So for coding, the answer is coded as 0, but it would not be considered a nonsensical response. The answer is wrong because a refusal is considered a wrong answer, but the patient's comment is logical and is related to the question. Finally, an example of a nonsensical response. The interviewer asks the patient to name the day of the week. The patient responds, "Sharon is my daughter." The interviewer asks the patient the question again to confirm that the patient is not hearing the question incorrectly. The patient answers with the same response. So the coding would still be 0 incorrect. The response is illogical and nonsensical. The answer is wrong, and the patient's comment clearly does not relate to the question, so it is considered nonsensical. So let's get into the nitty-gritty of the items that make up the BIMs, and we'll start with C0200, repetition of 3 words. Here is what this item looks like. Now, even though the coding option sequence is reversed between the LCDS and the IRF-PAI, the response option text and numbers match between the data sets. And for the purposes of this presentation and in the remaining slides, the coding responses depicted will use the sequencing shown in the IRF-PAI. So why is this important? The inability to repeat 3 words on the first attempt may indicate a memory impairment, a hearing impairment, a language barrier, or inattention that may be a sign of delirium or other health issue. So let's consider the steps for assessment for C0200. And I know we've already covered some basic BIMS interview instructions, so if you need to, pause the recording here and review those if you need to again. What's most important to keep in mind is that this is a structured cognitive interview, and following these steps closely will result in the most accurate assessment in coding. So step 1, you're going to say to the patient, "I'm going to say 3 words for you to remember. Please repeat the words after I have said all 3. The words are sock, blue, and bed." Interviewers need to use the words and related category cues as indicated. If the interview is being conducted with an interpreter present, the interpreter should use the equivalent words and similar relevant prompts for category cues. Immediately after presenting the 3 words, say to the patient, "Now, please tell me the 3 words." After the patient's first attempt to repeat the items, if the patient correctly stated all 3 words, say, "That's right. The words are sock, something to wear, blue, a color, and bed, a piece of furniture," stating the category cues. Category cues serve as a hint that helps prompt the patient's recall ability. And putting words into context stimulates learning and fosters memory of the words that the patient will be asked to recall in an item C0400 Recall. So let's think about coding and next steps. If the patient recalled 2 or fewer words, code C0200 repetition of 3 words according to the recall on this first attempt. Then, next, say to the patient, "Let me say the 3 words again. They are sock, something to wear, blue, a color, and bed, a piece of furniture. Now, tell me the 3 words." If the patient still does not recall the 3 words correctly, you may repeat the words in category cues one more time. Okay, some things to consider. If the patient does not repeat all 3 words after 3 attempts, reassess their ability to hear. If the patient can hear, move on to the next question. If the patient is unable to hear, attempt to maximize hearing, maybe alter the environment or use a hearing amplifier before proceeding. So how do we code the patient's response? Record the maximum number of words that the patient correctly repeated on the first attempt. And this number will be between 0 and 3. So for example, if they said bed, blue, and shoe, you would use code 2, 2. The words may be recalled in any order and in any context. For example, if the words are repeated back in a sentence, they would be counted as repeating the words. However, do not score the number of repeated words on the second or third attempt, as this may help the patient in learning the item. And do not record the number of attempts the patient needed to complete. So here are some coding response options for C0200, repetition of 3 words. Code 3, if the patient repeated all 3 words on the first attempt. Code 2, if the patient repeated only 2 of the 3 words on the first attempt. Code 1, if the patient repeated only 1 of the 3 words on the first attempt. And code 0, none, if the patient did not repeat any of the 3 words on the first attempt. Now let's take a look at C0300 temporal orientation. Let's take a close look at this item for IRF-PAI. The assessment instrument for C0300 is comprised of 3 sections. C0300A, able to report correct year, C0300B, able to report correct month, and C0300C, able to report correct day of the week. And again, even though the coding option sequence is reversed between the LCDS and IRF-PAI, the response option text and numbers are the same between the data sets. So why is this item important? A lack of temporal orientation may lead to decreased communication or participation in activities. And not being oriented may be frustrating or even frightening. And again, item rationale was refined to enhance clarity in the IRF-PAI. So what is temporal orientation? In general, it's the ability to place oneself in correct time. And for the BIMS, it's the ability to indicate the correct date in current surroundings. Now let's take a look at the steps for assessment. And again, I recommend that those of you who are not familiar with this item, be sure to read through the steps in your setting-specific guidance manual and have a solid understanding of these before you attempt this assessment. We're going to start by asking the patient each of the 3 questions in item C0300 separately, meaning that you should ask the question, wait for a response to that question before asking the next question. You're going to allow the patient up to 30 seconds for each answer, and do not provide clues. Now, I know that's a long time to wait, but it's important to ensure that you're giving the patient adequate time to hear, process, and respond to what you're saying. If the patient specifically asks for clues, like, is it bingo day? Respond by saying, I need to know if you can answer this question without any help from me. So for C0300A, able to report the correct year, start by asking the question, please tell me what year is it right now? Then consider the following coding response options. Code 3, correct, if the patient states the correct year. Code 2, missed by 1 year, if the patient's answer is incorrect and is within 1 year from the current year. Code 1, missed by 2 to 5 years, if the patient's answer is incorrect and within 2 to 5 years from the current year. Code 0, missed by greater than 5 years or no answer, if the patient's answer is incorrect and is greater than 5 years from the current year, or the patient chooses not to answer the item, or the answer is nonsensical. Then you can ask the question for C300B, able to report the correct month. So ask the patient, what month are we in right now? And consider these responses. Code 2, accurate within 5 days, if the patient's answer is accurate within 5 days, counting the current date as day 1. Code 1, missed by 6 days to 1 month, if the patient's answer is accurate within 6 days to 1 month, counting the current day as day 1. Code 0, missed by greater than 1 month or no answer, if the patient's answer is incorrect by more than 1 month, or the patient chooses not to answer the item, or the answer is nonsensical. Now remember, count the current day as day 1 to determine whether the response was accurate within 5 days, code 2, or missed by 6 days to 1 month, code 1. Here's something important to consider. In most instances, it will be immediately obvious to choose which code to select. In some cases, you may need to write the patient's response in your notes and go back later to count the days if you're unsure whether the date given is within 5 days. Now let's look at the final question regarding temporal orientation. C0300C, able to report the correct day of the week. Ask the patient, what day of the week is today? Then consider these response options. Code 1, correct, if the answer is correct, or code 0, incorrect, or no answer, if the answer is incorrect, or the patient chooses not to answer the item, or the answer is nonsensical. But note, in order to code 1 correct, the patient must be able to report the correct day of the week. Reporting the date is not considered a day of the week. Now let's look at the final item for the BIMS, C0400 Recall. So recall, can you recall what happened some 20 slides ago? Well, that's exactly what we'd be asking of our patients. The item C0400 Recall is comprised of 3 sections. C0400A, able to recall sock, C0400B, able to recall blue, and C0400C, able to recall bed. And again, even though the coding option sequence is reversed between the LCDS and IRF-PAI, the response option text and numbers are the same between the data sets. So what is the rationale for C0400? Many persons with cognitive impairment can be helped to recall if provided cues. Providing memory cues can help maximize patient cognitive function and decrease frustration for those patients who respond. And just as I said before, understanding these steps for assessment is key to an accurate assessment in the associated coding. So let's review. You're going to ask the patient the following. Let's go back to an earlier question. What were those 3 words that I asked you to repeat? You're going to allow 5 seconds for spontaneous recall of each word. For any word that is not correctly recalled after 5 seconds, provide a category cue used in C0200, repetition of 3 words. Category cue should be used only after the patient is unable to recall 1 or more of the 3 words. Allow up to 5 seconds after the category cue for each missed word to be recalled. And again, please refer to the basic BIMS interview instructions for additional directions. So for each of the 3 words that the patient is asked to remember, you will use the following coding guidance. Code 2, yes, no cue required. If the patient correctly remembers the word spontaneously without cueing. Code 1, yes, after cueing, if the patient requires the category cue to remember the word. And code 0, no, could not recall, if the patient cannot recall the word even after being given the category cue, or if the patient responds with a nonsensical answer or chooses not to answer the item. Okay, some things to remember. On the first try, without cueing, the patient names multiple items in a category, one of which is correct. Well, then they should be coded as correct for that item. If, however, the interviewer gives the patient the cue and the patient then names multiple items in that category, the item is coded as could not recall, even if the correct item was in the list. So now let's look at C0500, the BIMS summary score. This item identifies the total score for all the questions that were asked in C0200 through C0400. So this total score decreases the chance of incorrect labeling of cognitive ability and improves detection of delirium. It provides staff with a more reliable estimate of the patient's function and allows staff interactions with patients that are based on a more accurate impression about the patient's ability. The steps for the BIMS assessment, the BIMS summary score are as follows. Now, after completing C0200 to C0400, you're going to add up the values for all questions from C0200 through C0400. Now, don't add up the score while you're interviewing the patient, and instead focus your full attention on that interview. So C0500 coding is pretty simple. You're going to start by entering the total score as a 2-digit number on your assessment instrument. And the total possible BIMS score ranges from 00 to 15. If the patient chooses not to answer a specific question, that question should be coded as incorrect, and the item should count in the total score. If, however, the patient chooses not to answer 4 or more items, then the interview is coded as incomplete. Then for IRF, complete the staff assessment, item C0900, memory recall ability. And remember, to be considered a completed interview, the patient had to attempt and provide relevant answers to at least 4 of the questions included in C0200 to C0400C. To be relevant, a response only has to be related to the question. It's logical. It does not have to be correct. You may recall, sorry for the pun, we covered this concept of completed interview and relevant responses earlier in the presentation. So you would use code 99, unable to complete the interview, if the patient chooses not to participate in the BIMS, 4 or more items were coded 0 because the patient chooses not to answer or gave a nonsensical response, or if any of the BIMS is coded with a dash. And also remember, a 0 score does not mean the BIMS was incomplete. To be incomplete, the patient had to choose not to answer or give completely unrelated nonsensical responses to 4 or more of the items. Now let's consider this situation. Occasionally, a patient can communicate but chooses not to participate in the BIMS and therefore does not attempt any of the items in the section. Now this would be considered an incomplete interview. So you'll enter code 99 for C0500, the BIMS summary score. And for IRF, then you would complete C0900, the staff assessment for mental status. There are a few additional changes to Section C guidance for C0600 and C0900 that include minor changes to skip patterns, new examples added for depicting when to code C0600, and clarification to coding instructions. And we invite you to refer to the IRF-PAI for more additional information regarding those changes. Now let's look at C1310, signs and symptoms of delirium, taken from the confusion assessment method, also known as the CAM. Now this is a revised item for LTACs and a new item for IRFs, and it consists of 4 elements. A, acute onset mental status changes, B, inattention, C, disorganized thinking, and D, altered level of consciousness. So why is understanding delirium in our patients so important? Well, delirium is associated with increased mortality, functional decline, development or worsening of incontinence, and behavior problems, withdrawal from activities, and rehospitalization and increased length of facility stays. Delirium can be misdiagnosed as dementia, and a recent deterioration in cognitive function may indicate delirium, which may be reversible if detected and treated in a timely fashion. Delirium may be a symptom of an acute treatable illness, such as an infection or a reaction to a medication. So how are we defining delirium? Delirium is considered a mental disturbance characterized by new or acutely worsening confusion, disordered expression of thought, a change in the level of consciousness, or hallucinations. So let's consider the steps for assessment. And it's so important to note that we want to collect this information as close to the time of admission and discharge as possible. Now, specifically for LTACs, complete only if A0250 is 01 admission, 10 planned discharge, or 11 unplanned discharge. Note that the LCDS does not contain C0900, the staff assessment for mental status. So step 1 is a little different between LCDS and IRF-PAI. So for my LTAC friends, let's start with you guys first. You're going to observe the patient's behavior during the cognitive assessment, the BIMS item C0200 to C0400, or other cognitive assessment for signs and symptoms of delirium. Now, for my IRF friends, we're going to observe the patient's behavior during the cognitive assessment, BIMS item C0200 to C0400, the staff assessment for mental status C0900, or other cognitive assessments for signs and symptoms of delirium. Now, beyond that step, the steps for assessment for LTAC and IRF match. We're going to review the medical record documentation to determine the patient's baseline status, fluctuations in behavior, and behaviors that might have occurred during the assessment period that were not observed during the cognitive assessment, like the BIMS. We're going to observe the patient's behavior during patient interactions and consult with other staff, caregivers, and others in a position to observe the patient's behavior during the assessment period. So for coding C1310, acute onset mental status change, you're going to ask, is there evidence of an acute mental status, Is there evidence of an acute change in mental status from the patient's baseline? So you would code 0, no, if there's no evidence of acute mental status change from the patient's baseline, or code 1, yes, if the patient has an alteration in mental status observed in the assessment period or in the cognitive assessment, like the BIMS, that represent an acute change from baseline. So let's review some examples of what would be considered an acute onset mental status change. A patient who is usually noisy or belligerent becomes quiet, lethargic, or inattentive. A patient who is normally quiet and content suddenly becomes restless or noisy. And a patient who usually is able to find their way around their living environment begins to get lost. Let's look at C1310B, inattention. Did the patient have difficulty focusing attention? For example, being easily distractible or having difficulty keeping track of what was being said? So you're going to, number 1, assess attention separately from level of consciousness. And an additional step to identify difficulty with attention is to ask the patient to count backwards from 20. So for 1310, response option language is the same for inattention, disorganized thinking, and level of consciousness. However, their meanings are a bit different for each element. So let's take a look at the coding instructions specifically for C1310B, inattention. So you're going to code 0, behavior not present, if the patient remains focused during the interview and all other sources agree that the patient was attentive during other activities. Code 1, behavior continually present, does not fluctuate, if the patient had difficulty focusing attention, was easily distracted, or had difficulty keeping track of what was said, and the inattention did not vary during the assessment period. All sources must agree that inattention was consistently present to select this code. You're going to code 2, behavior present fluctuates, if inattention is noted during the interview or any sources report that the patient had difficulty focusing attention, was easily distracted, or had difficulty keeping track of what was said, and the inattention varied during the interview or during the assessment period, or if the information sources disagree in assessing level of attention. Let's consider these definitions regarding inattention and fluctuation. So inattention is the reduced ability to maintain attention to external stimuli and to appropriately shift attention to new external stimuli. A patient seems unaware or out of touch with the environment, like they're dazed, fixated, or maybe they have darting attention. Whereas fluctuation really is around a behavior that tends to come and go or increase and decrease in severity. The behavior may fluctuate over the course of the interview or during the assessment period. Fluctuating behavior may be noted by the interviewer, reported by the staff or family, or documented in the medical record. Now for C1310C, disorganized thinking. Was the patient's thinking disorganized or incoherent, rambling or irrelevant conversation, unclear or illogical flow of ideas, or unpredictable switching from subject to subject? Consider this definition for disorganized thinking. It's evidenced by rambling, irrelevant, and/or incoherent speech. So again, you'll see the same responses for C1310C, disorganized thinking, but again, the instructions are a little different. You're going to code 0, behavior not present, if all sources agree that the patient's thinking was organized and coherent, even if the answers were inaccurate or wrong. You're going to code 1, behavior is continually present, does not fluctuate, if during the interview and according to other sources, the patient's responses were consistently disorganized, incoherent, conversation was rambling or irrelevant, ideas were unclear or followed illogically, or the patient unpredictably switched from subject to subject. Code 2, behavior present, fluctuates, if during the interview or according to other data sources, the patient's responses fluctuated between disorganized, incoherent, and organized, clear. Also code fluctuating if information sources disagree. So now let's take a look at C1310D, altered level of consciousness. Did the patient have an altered level of consciousness as indicated by any of the following criteria? Vigilant, lethargic, stuporous, comatose. Let's see how we define these criteria. A vigilant person is one who startles easily to any sound or touch. A lethargic patient would repeatedly doze off when you're asking a question, but would respond to voice or touch. For stupor, this patient is very difficult to arouse and keep aroused for the interview. And a comatose patient cannot be aroused despite shaking and shouting. Once again, the response options are the same, but the instructions are specific to coding C1310D, altered level of consciousness. You're going to code 0, behavior not present, if all sources agree that the patient was alert and maintained wakefulness during the conversation, interviews, and activities. You're going to code 1, behavior present, behavior continuously present, does not fluctuate, if during the interview and according to other sources, the patient was consistently lethargic, stuporous, vigilant, or comatose. Code 2, behavior present, fluctuates if during the interview or according to other sources, the patient's level of consciousness varied. For example, the patient was at times alert and responsive, while at other times the patient was lethargic, stuporous, or vigilant. Also code fluctuating if information sources do not agree. Note, a diagnosis of coma or stupor does not have to be present for staff to note this behavior in this section. So what does this mean when considering an indication of delirium for your patient? This is found in your guidance manual, but let's break it down a little bit better to understand what it means. Basically, there are 3 conditions with regards to how your patient scored on C1310. Condition 1. The first condition requires that at least one of the following can be true. C1310A is 1, or C1310B, C, or D is a 2. So on the screen, you see how the scoring of C1310 indicates the first condition. Condition 2, assuming that the first condition is met, the second condition must also be met. And that is that item C1310B in attention is coded as a 1 or a 2. And then condition 3, finally assuming that the first and second conditions are met, the third condition in order to indicate delirium is that item C1310C, disorganized thinking, is coded as a 1 or 2, or item C1310D, altered level of consciousness, is coded as a 1 or 2. With all 3 conditions applying, an indication of delirium could be considered. So let's review here what we learned today. There are new revised data elements identified for Section C cognitive patterns. They are C0100, C0200 through C0500, and C1310. New for LTAC, C0200 to C0500, brief interview for mental status. This item is intended to determine a patient's attention, orientation, and ability to register and recall new information. Now, new for IRF and revised for LTAC, C1310, signs and symptoms of delirium, is intended to identify if the patient has signs and symptoms of delirium. So we do welcome questions, and we would like you to submit a question regarding this presentation. If you care to do that, please send it to pactraining@econometricainc.com by June 3rd, 2022. In June, a practice coding workshop will be held, and we encourage you to attend. Based on the review of the questions submitted, select questions will also be discussed in a Q&A session during the June 2022 virtual event. Thank you for reviewing. We look forward to sharing more insights at the June 2022 virtual event.